Assalamu alaikum. Mansoor Ahmed is my name, and I'm very impressed with the audience around here. Great audience, and I would enjoy talking to them. And I think after so much wisdom in Imran's talk, I'm still stuck up with that, so I'm unable to start as yet. Next, please. Yes, go on. Yeah, go on, please. Where is the slide? I thought they told me you were going to do it. Okay. So I've actually modified my talk a little, because we all know about the risk of diabetes. And at the same time, I think the newer drugs that are available, we need to talk about them and increase the use of these drugs, because in our society we're still stuck up with most of the older drugs, which may not be as beneficial. Anyway, diabetes significantly increases cardiovascular risk. 70% of type 2 diabetic deaths are CV related, cardiovascular related. Management should, I have to use two of them, okay. Okay, I've got the pointer now. So management should address both glycemic control and protection. Okay, now these are certain the diabetic drugs: metformin, SGLT2 inhibitor, GLP-1 receptor agonist, DPP-4 inhibitors, insulin, sulfonylureas, and thiolidinones, TZS as they are in their short form. Now we just discussed these drugs very briefly and what to do and how they work. So SGLT2 inhibitor, they work through inhibiting glucose reabsorption in kidneys, promote glycosuria, lower blood pressures, improve volume status, and reduce preload and afterload. This is the basis of what we are going to see. This is more of the same in graphic form, and these are three drugs which are available, I think, with us: canagliflozin, dapagliflozin, and empagliflozin. Okay, now GLP-1 receptor agonist, this is another group of drugs already been mentioned just before by Imran, and I think the very first talk was based on this group of drug, which really have changed the dynamics of diabetic treatment. And to me, this is one of the most dynamic drugs that I prescribe to many of my patients, and it works wonders. It mimics incretin hormones, enhances insulins, suppress glucagon, slow gastric emptying, promotes satiety, and there is modest weight loss. In fact, now with tirzepatide, weight loss is not just modest, but pretty good. So there are so many outcome trials with liraglutide, already mentioned, leader in sustained trial, and of course there is greater atherosclerotic benefit and heart failure. Not heart failure, but we have not established benefit in heart failure, but of course for atherosclerotic vascular disease. DPP-4 inhibit breakdown of incretin hormones, neutral CV outcomes in trials, some increase heart failure risk, but generally well tolerated. And it's one of the commonest drugs that's used. Sulfonylureas, there is a risk of hyperglycemia, controversial cardiovascular effects. Older drugs likely to increase the CV events, and you should use it in patients with coronary artery disease because the risk of hypoglycemia. We actually underestimate hypoglycemia. Many patients come back with HbA1c of 6. I think that scares me. Although they're very happy it's controlled, but remember, this is an average. So sometimes they're going down to 3, other times they're going down to 5. So going down to 3 is a definite risk factor for precipitation of angina, making it unstable, and even an infarct. So got to be a little careful with that. TZDs, as the name is difficult, pioglitazone may reduce stroke and MI, as the data shows, but it's definitely contraindicated in heart failure because of its fluid retention properties. The benefit and risk must be assessed individually with this group of drugs. So these are key cardiovascular outcome trials with diabetes, that's EMPA-REG, CANVAS, we have all declare, leader, sustain, they've all been mentioned already, so I won't go into that detail. So, but of course, EMPA-REG with protection of kidney is very obvious. 38% reduction in cardiovascular deaths, 35% in heart failure hospitalization, early separation of curves, and beyond, benefits beyond glucose lowering. This declared TIMI 58 on dapagliflozin, reduced hospitalization from heart failure, and neutral effects on MACE and cardiovascular benefits across primary and secondary prevention both. And this works both in diabetics and non-diabetics. So leader and sustain trial already been mentioned before with GLP-1, so there's no point spending time on it. Of course, we should tailor our therapy by cardiovascular profile of all our diabetic patients. So heart failure or CKD prefer SGLT2 inhibitors, ASCVD, GLP-1 RAs beneficial, low risk metformin first, and of course monitor progression of the disease. There is a special population which is elderly. So elderlies, you must be very, very careful. Increase the dose, adjust the doses slowly as per to prevent hypoglycemia, which can be very common in these patients. Someday they are unable to eat, so they may get hypoglycemia, so you need to be very careful with these. So CKD dose adjustment is needed, and multimorbidity should also be considered in these patients. Combination strategies, metformin plus SGLT2 inhibitor or GLP-1 RAs, both are possible and they should be used. They are synergistic cardiovascular and glycemic control, but do monitor renal failure, blood pressure, and side effects. So current guidelines recommend early use of SGLT2 and GLP-1 RAs in cardiovascular disease. Move away from stepwise HbA1c only approach. The target should not be only HbA1c, but the individual, the person you are treating. So individualized risk-driven therapy. This is a case where prior MI, so GLP-1/8 for cardiovascular atherosclerotic benefit, and of course study 2 there is heart failure, so SGLT2 has clear-cut benefits here. So in summary, not all diabetic drugs are equal in cardiovascular protection. SGLT2 should be preferred in heart failure and chronic kidney disease protection. GLP-1 RAs should be used whenever there is a atherosclerotic cardiovascular protection is needed. Metformin remains foundational, as has been discussed already. Thank you very much. Oh, I can speak more. ठहर जाओ, वही भी time है मेरे पास. And thank you so much. It's been such a wonderful morning and a great show once again. I've been attending it for I think ever since it was initiated, and now it's grown, and it's wonderful to see the youngsters growing into it and of course enjoying it. I'm enjoying all the talks. The talks have improved so much, and with this 10 minutes I think we have to stay focused on our subject rather than reading the whole chapter, which is still very common in our society. We start from the introduction और फिर सारा का सारा पढ़ देते हैं, तो next speaker के लिए कुछ नहीं बचता, and that repetition actually bores you up. Attention remains for 5 minutes. So your talk should be message based, clear cut in message, rather than just producing data and data and data and data.